Okay, so in this lecture we'll be looking at Chapter 51 of your Med-Surg book, and this is caring for patients with diabetes. Diabetes mellitus is a metabolic disorder which affects carbohydrate, protein, and fat metabolism. This is becoming a huge epidemic in our society. Researchers believe that metabolic syndrome increases one's risk for diabetes. This group of symptoms include obesity, and this is in the abdomen area, more of an apple shape, high blood pressure, high triglycerides, low density lipoprotein, which is bad cholesterol, and low high density lipoprotein, which is your good cholesterol. What is diabetes mellitus? As I previously stated, it's a metabolic disorder of the pancreas affecting carbohydrate, fat, and protein metabolism. It affects approximately 26 million people in the United States, with approximately 7 million undiagnosed. It is associated with long-term complications. The incidence of diabetes is higher in African Americans, Latinos, Native Americans, and Asian Americans. As our population becomes more sedentary, obese, with a longer lifespan, we will see an increase in this disorder significantly. Diabetes is the 7th leading cause of death in the United States. And due to the chronic nature of this disease, many people affected will suffer debilitating and life-threatening experience before death. Diabetes affects every system of the body, so it's important to remember that. Type 1 diabetes, also known as insulin-dependent diabetes mellitus, is the absence of insulin produced by beta cells in the islets of Langerhans of the pancreas. Onset is most likely in childhood and adolescence. Type 2 diabetes, which is non-insulin-dependent diabetes mellitus, is characterized by insulin resistance or inadequate insulin production. More common in aging adults, ages 40 to 64, and is also becoming a disease very well known in obese children. The pancreas serves as an exocrine and an endocrine gland. The presence of insulin stimulates the diffusion of glucose into the cells. So we have the islets of Langerhans, and in those we have beta cells. Beta cells produce insulin in 65 to 80% of those total islet cells. In the islets of Langerhans, we also have alpha cells, which produce glucagon, and that's anywhere from 15 to 20% total islet cells. Insulin has 3 different functions. One, it carries glucose into the cells for energy. It promotes the liver's storage of glucose as glycogen. And 3, it inhibits the breakdown of glycogen back into glucose. Importantly, think of insulin as a bus transporting glucose into the cell for energy. So, I mean, it's really, when it comes down to it, pretty simple. The insulin is used to transport that glucose into the cell for energy. In type 1 diabetes, IDDM, beta cells cease production of insulin and need insulin for replacement. So in these patients, you're going to need insulin for them as part of their care. Onset is most likely in children and adolescents, but it really can occur at any age. Type 1 diabetes has an abrupt onset. It happens pretty quickly. And evidence shows some support for a link, however the exact cause is unknown. Researchers suggest that type 1 diabetes is autoimmune related. There's a possible genetic mutation that causes killer T-cell lymphocytes to attack and destroy the insulin produced by the beta cells. There is some good news in this. INGAP, which is islet neogenesis associated protein, it's also known as exelin, has found to differentiate into beta cells that produced insulin when used on stem cells. So this sounds pretty promising. There are two forms of type 1 diabetes. There's immune-mediated, and this is the most common form. The body's immune system destroys itself, as I explained earlier. And there's idiopathic, which is a rare form, which there is really no known cause. In type 2 diabetes, the beta cells of the islets of Langerhans secrete high levels of insulin into the blood to offset the huge amount of glucose level. But the hyperglycemia continues due to a deficiency in the transmembrane glucose transporters on the surface of the cells. These transporters help form channels that help diffuse the glucose into the cell. Again, transporting that glucose into the cell. These transmembrane glucose transporters are not there. Type 2 is a hyperglycemic condition that occurs despite the availability of insulin, as previously discussed. This has more gradual onset of symptoms, and there is definitely a genetic predisposition for this type 2 diabetes. It can be an inherited disease with often obesity as a triggering factor. And it also can lead to insulin-dependent diabetes due to overstimulation of those beta cells being used. So, signs and symptoms of diabetes mellitus. One thing I want you to think of is the 3 P's. Polyuria, which is excessive urination, and polydipsia, which is excessive thirst, and polyphagia, which is excessive hunger. These 3 classic symptoms can be seen in both types of diabetes, so these 3 P's are very important. And as I said before, type 1 is abrupt, while type 2 has a slower onset. I put sticky with urination. Sometimes you'll find maybe a patient accidentally voids on the floor or something, and you can find that the floor is very sticky. So that's an indication that the patient's throwing too much glucose even before they may be ever diagnosed. Excessive thirst shows signs of dehydration. And these patients, although they're polyphagic, have excessive hunger, but lose weight. Other signs and symptoms will be high glucose in blood levels, high glucose in urine levels, again, causing that urine to be sticky. They can have blurred vision, nausea and vomiting, again, with some weight loss, extreme weakness and fatigue. And these patients are going to have some mood changes and be pretty irritable. So let's take a look at diagnostics findings for diabetes mellitus. Here we have blood glucose levels, and this table is table 51-2 on page 862. We have our random blood glucose, and this can be taken at any time of the day. Greater than 200 suggests diabetes mellitus. Then we look at the fasting blood glucose, and that's fasting 8 to 12 hours. And 70 to 110 is normal for non-diabetics. Again, 70 to 110 is in non-diabetics. Anything greater than or equal to 110 but less than 126 is considered diabetic. Then we have the postprandial glucose, which is greater than 140 but less than 200 in diabetic patients. Then there is the oral glucose tolerance test, which you take a glucose substance and then show back at the lab 2 hours later. Anything greater than 200 suggests diabetes. Then we have the glycated hemoglobin, which is a 3-month average of glucose levels. The HbA1c, which is also the glycated hemoglobin, is the amount of glucose stored by the hemoglobin is elevated above 7% in these patients. It is important to know that this monitors 120-day, which is 3 months, of glucose levels. Reasons for this being elevated above 7 would be a newly diagnosed patient with diabetes, maybe a patient that is non-compliant, and the third would be the patient who is inadequately being treated for their diabetes, and they may need some dose adjustments. Again, this can be found on page 862 of your